Thank you for joining ReachMD XM157 for this month's special series, Spotlight on Neurology and Psychiatry.
Major depressive disorder and low bone mass in women, an unrecognized risk factor. You're listening to ReachMD XM157, the channel for medical professionals. Welcome to our ReachMD special series exploring psychiatry. I'm your host, Dr. Gary Kohn, and joining me is Dr. Giovanni Cizza, who is an MD PhD clinician with the Clinical Endocrinology branch of the NIH in Bethesda, Maryland. Dr. Cizza and his team recently published an original investigation in the Archives of Internal Medicine, and that's going to be our topic today. We're going to be talking about low bone mass in premenopausal women with depression. Dr. Cizza, welcome to ReachMD. Thanks for taking some time to be with us today. Giovanni, maybe before we talk about your research and maybe what some of the messages are for our physicians out there, could you give us a little background on yourself, your medical background, and how you got into this area of investigation?
As a training, I am an endocrinologist, and I always had some interest in the potential connection between the brain and the body. And I think that an endocrinologist is well positioned to ask that question. Psychiatrists are also well positioned, but they come from the brain down and we go from the body up. And usually the body gland where these two disciplines meet, if you wish, is the hypothalamus. The hypothalamus is the gland that basically controls, it's like the orchestra director, is the gland that controls all the other glands, including the adrenals, which are the glands that produce the stress hormone cortisol. And depression, which is the topic of this article, can definitely be regarded as a state of chronic stress.
Let's talk a little bit about this article. The title of the article is Low Bone Mass in Premenopausal Women with Depression, which leads us to believe that you concluded there was some connection between the two. Could you give us just a brief summary of the results and conclusions from your study?
Yes. In this sample of premenopausal women, average age about 41, suffering from depression, there was decreased bone mass at all sites, skeletal sites, especially the femur, but also the anterior posterior spine. The prevalence of pathological bone mass, that is a condition that needs definitely follow-up and possibly pharmacological treatment, was greater in women with depression than in controls. And biological factors, including cytokines and hormones, were definitely one of the potential link between a psychological condition, depression, and a physical condition, low bone mass.
And what about the magnitude of that association? How would you compare that to other things that we have heard about, normally considered to be risk factors for osteoporosis?
That's a very good question. And as we all know, immediately past the menopause, there is a bone loss, which is due to lack of estrogen. That bone loss is about 2 to 3% a year. So these women with depression had a bone loss, if you wish, a lower bone mineral density compared to the appropriate control, which was in the order of magnitude of about 6%. So one could say that having depression is equivalent to 2 years of rapid postmenopausal bone loss. It is, if we want to compare to other known factors of osteoporosis, such as lack or paucity of calcium intake or smoking, we also have similar magnitude. That is, depression induces a bone loss which is comparable to smoking or not drinking enough milk.
Would it be accurate to say that while many of us would expect the aging relationship, and many of us talk to our patients about smoking and calcium intake, I'm guessing not too many practicing physicians make that association with depression. Has that been your experience, or is that how you see it?
Yes, definitely. Unfortunately, the awareness that a psychological condition such as depression may cause bone loss, as well as other medical consequences, including cardiovascular disease, hypertension, and others, is not, unfortunately, very common. So definitely that is a problem. But if I may, I also would like to add that it's not so easy to recognize depression, even for a practicing physician. If you do not ask the right questions, and there is some cultural stigmata on the part of the patients to volunteer center information, depression can definitely go unrecognized. And in my own experience, I'm an endocrinologist, but when we were conducting this study, of course, there was a psychiatrist who was was evaluating the patients, and I always was very surprised after the psychiatrist, his name is Dr. Pedro Martinez, would conduct his interview, or the research nurse, who was also trained from a psychological point of view, Sarah Torvik, they would come out, and a patient that to me appeared euthemic and not depressed had very high scores of depression.
If you've just tuned in, You're listening to a special series exploring psychiatry on ReachMD, XM157, the channel for medical professionals. I'm your host, Dr. Gary Kohn, and I'm speaking with Dr. Giovanni Cizza, and we're discussing low bone mass in premenopausal women with depression. Giovanni, you talked about the difficulty in recognizing maybe subclinical depression in our outpatients. Let me just clarify something in your study. Were the women who were defined to have depression in this study, were they all on medications, some on medications?
Most of them were. The number is 89%. This study was prospective. So that is, we wanted to follow the subjects for 3 years. So it would have been definitely not ethical to deprive them of a pharmacological treatment that they needed otherwise. And that's one of the features, and if you wish, maybe one of the limitations of the study, but we could not possibly do the study otherwise in humans. However, if I may add, there has been recently a study conducted in experimental animals where the animals experience bone loss as a result of severe stress. So there is data in, of course, not in human species, but in other species that depression can cause chronic stress, which is equivalent of depression, if you wish, can cause bone loss. And also, in this study, they identified the potential mechanisms, namely alteration in the sympathetic tone, which is, as you know, one of the two main effectors of the stress system. One is the adrenal axis and the cortisol, and the other are the catecholamines, which are secreted also by a part of the adrenal gland called the medullary gland.
So we've got obviously some human studies, we've got some animal studies. What's your group planning in the future in terms of future research in this area?
I think it is extremely important to conduct long-term studies. The POWER study was long, 3 years, but I wished we could have done a longer study. Maybe in the future we will follow those subjects or subjects with similar conditions for a longer period of time. And by that I mean 8-10 years. Definitely we need to do a similar study in men, because although the difference in bone mass that we see in depressed men compared to depressed women is smaller, if you are a man, you need to lose less bone to be at greater risk for fractures. So I think it would be important to conduct a similar study in men as well.
Giovanni, when this study came out in archives, could you share with us some of the feedback you've gotten from your colleagues, either positive or negative? Were people surprised? Were you surprised?
Well, my collaborators and co-authors, this was a collaborative study. Many institutes were involved, and there was a large group. There are more than 10 authors, but many more people participated. Some are acknowledged. Of course, they were thrilled. They were very pleased. I must say that it's never easy, but in this case it was not easy to publish the study, in part because of the innovative message. As far as colleagues are concerned, they were surprised, and now I hope, even in our outpatient clinic, when we see patients with osteoporosis, I think they're thinking about depression a little more often. So, and there is some skepticism, and there is some resistance in certain groups, but I'm not sure how substantiated by facts this resistance is as compared to being dogmatic. And I'm alluding to a group of people who really do not believe that such connection between the psyche and the body exists.
We've thought that many times before, and sometimes it just takes a while to go along. Do you think there are teaching opportunities? For example, do you have the opportunity to lecture or teach residents or fellows or students? Do you think this is something we should be putting out there as more standard teaching about the subject?
I do think so. I think that the curriculum of medical school should include a little more of these topics. I'm trying this year to go to 2 or 3 meetings where I usually do not go. I will go to a meeting of gynecologists because this is a women issue. I'm going to a meeting of osteoporosis in China, hopefully. And so I'll try to spread the word in this sense.
We talked briefly about meta-study that you are thinking about or involved in now. Could you share a little bit about that?
Well, for the non-initiated, the meta-analysis is the Cadillac of a traditional review in the sense that it looks at all the studies that have been published, but it also puts a different weight on each study based on several factors, the most important being the sample size. So it gives you an aggregate picture that is, if you wish, better than the single pieces of the puzzle. So I'm working on a meta-analysis that hopefully will summarize the existing studies. There are about 17 studies. And some results have been presented to national meetings, including the Endocrine Society. But happy to share with you already that the studies are very consistent in showing a difference in bone mass, which is approximately 5% at the lumbar spine, and is a little more at the femoral neck. So again, those studies are consistent. The studies are heterogeneous because some were conducted in Europe, some in the US, some in China, older women, younger women, different methods of diagnosing depression. Of course, if you do a large epidemiological study, all you can do is administer or in some studies mail a questionnaire, whereas in the smaller studies like mine, it is possible to sit with the subject and do a face-to-face clinical assessment. So there is the term is heterogeneity between studies. But in spite of this heterogeneity, the message is clear and loud.
Well, we look forward to seeing that published. Are other groups, other than at the NIH, pursuing other avenues of research in this area that you know of?
Yes. Unfortunately, it's a little less than a few years ago, and this may be a general phenomenon due to the paucity of funding for biomedical research. It is an active area, and there are very good groups in the US as well as in Europe.
What would be the take-home message for the practicing physicians out there?
I would give two messages. The first is a more general one, that is, when I share with my patients the fact that depression can cause something physical, bone mass, the reaction was relief. Those women said, I'm so glad to hear that because I am now able to tell my spouse, my children, that this is not all in my head. This is something real, tangible, measurable. So I think this is very important, and I hope this helps lift the stigma and the silence that there is too often around this condition, this suffering condition, which unfortunately to some extent we all share, depression. The practical message is, if a subject, especially if this subject is a young premenopausal woman, has a fracture, think also about depression. Do not exclude depression as a potential cause. And if a young woman comes to the office of a psychiatrist, the psychiatrist should think about osteoporosis and consider doing some medical testing, whether it's a physical examination and a family history, or it is a DEXA. It has to be decided on a case. DEXA is the test that is done, is a radiological test done to measure the bone mass. Has to be decided on a case-by-case basis. But these two specialties, psychiatrist and internist, should think, one, of the osteoporosis as a consequence of depression, and the other, depression as a cause for osteoporosis.
Giovanni, thank you for sharing your research with us. My thanks to Dr. Giovanni Cizza for being our guest. We've been discussing low bone mass in premenopausal women with depression. I'm Dr. Gary Kohn, and you've been listening to a special series exploring psychiatry on ReachMD XM157, the channel for medical professionals. To comment or listen to our full library of podcasts, visit us at reachmd.com. Register with promo code RADIO and receive 6 months free streaming for your home or office. Thank you for listening.
Listen all month as ReachMD XM157, the channel for medical professionals, features a special series, Spotlight on Neurology and Psychiatry.